Hello, my name is Dr. Brenda Christopher and I'm a sports and exercise medicine physician. This is a clinical examination video for the approach to a painful knee. We will start the knee examination by looking at specific tests for ligamentous and meniscal injuries. The ACL is assessed with an anterior draw, noting any laxity and comparing right to left. And here they're both equal, so I don't think there's any ACL pathology. So you can also assess the integrity of the ACL with alignments. Here I'm grasping the tibia in an anterior motion. As you can see, I struggle here, so modified Lachman's is by placing my thigh under the patient's femur, and this frees up my hands. So if laxity is noted on either the Lachman's or the anterior draw, you want to ensure that this is coming from the ACL and not the PCL. So a way of discriminating this is to ensure that the posterior draw test is negative or positive. So a posterior draw sign assesses the PCL, and I'm pushing downwards on the tibial tuberosities with my thumbs. So here we note whether there's a posterior sag sign, and if one of the tibial tuberosities is more prominent than the other, that's indicative of a posterior sag. I next palpate the medial collateral ligament, and the lateral collateral ligament, feeling for any crepitus or tenderness. I stress the MCL at 0 degrees and 30 degrees of knee flexion. I feel for any, I look for any opening of the joint and feel for any laxity, whilst applying an outward force with my bottom hand and using my top hand as a fulcrum. I always compare left to right. I test the integrity of the LCL at 0 degrees whilst pushing the lower leg inwards, and at 30 degrees. This movement is also known as a varus movement. Assessing for any joint opening. We assess the integrity of the menisci, which are 2 C-shaped shock absorbers which lie on top of the tibial plateaus, by applying a compressive and twisting force. So this is testing the lateral meniscus, and this is testing the medial meniscus. Apley's test is for meniscal injuries, and I provide a downward pressure or force in 2 C's. So I'm stressing each meniscus, the medial and the lateral. Thessaly's is a useful test because it uses the patient's body weight and it loads the meniscus. So here I ask the patient to weight bear on one flexed knee, and I turn them, which will load the medial meniscus and the lateral meniscus. Duck waddling is a useful test as this loads the posterior aspect of both menisci. Anterior knee pain is pain originating from the patellofemoral joint. Clark's test is often positive, where I ask the patient to tense this muscle and I apply a downward pressure. Relax, tense, relax, and tense, and relax. And if you can see, I'm resisting the upward motion of the patella. If this is painful, that's a positive Clark's test. Palpation of the underside of the patella is useful. First, I palpate the underside of the lateral aspect of the patella, and then the medial facet. Patellar tendinopathy often presents as pain on palpation of the superior pole, inferior pole, and insertion on the tibial tuberosity. If there is pain either side of the tendon, this is usually impingement of Hoffer's fat pad. For signs of bursitis, it's important to know the anatomy of the knee. For prepatellar bursitis and Pez-Anserine bursitis, you're looking for tenderness and fluctuations. For Baker's cyst, you're feeling for a palpable mass. There are a couple of tests for effusions, which are usually down to degenerative, septic, or crystal arthropathies. The first test for moderate to large effusions, where you milk the suprapatellar pouch in a downward motion and blot the patella. The second test is for a smaller effusion, and it's called the medial bulge test, where I empty the medial compartment and then push the fluid back with a downward motion on the lateral aspect of the knee, whilst looking here for a fluid bulge. Knee osteoarthritis is common in the older age group, and often you'll be able to demonstrate a tender medial or lateral joint line. Patients may exhibit a varus deformity of the knee joint, and there may be associated muscle atrophy and a bland joint effusion. A diagnosis that shouldn't be missed that can present as knee pain is a stress fracture of the tibia. It's useful to palpate the entire length of the tibia, usually on the medial aspect, and identify any points of tenderness. If the tenderness is here, you can also percuss down the length of the tibia, and this should reproduce pain and symptoms where the tenderness was identified. Another way to test for a stress fracture is to ask the patient to weight bear through one leg, the painful leg, and to hop. Pain on hopping, single leg hopping, is indicative of a stress fracture. Thank you, Chad. Thank you for watching the Stanford 25 knee examination video. Please subscribe and visit our website for further information.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.